A very good morning to all the attendees, and we are thankful for someone to join us. We'll be talking about a new molecule in our midst, Brolucizumab, and we have had a very pleasant and a long experience with the molecule, and therefore we want to go ahead and speak about Brolucizumab all the way. I'd like to introduce the speakers. That is myself. I am presently posted at Army Hospital Research and Referral at Delhi, Kent. I am a professor of ophthalmology and a vitreoretina surgeon. Next slide, please. With me today is Wing Commander Avdesh Oli. He has joined us from Command Hospital Air Force, Bangalore. He is a professor of vitreoretina surgery. He is a graduate and postgraduate of Armed Forces Medical College. He stood first in college as well as second in merit in Maharashtra University of Health Sciences during his MS Ophthalmology. And when he was at L.V. Prasad Eye Institute, he stood first amongst all the fellows who gave the exam, including the international fellows. He has multiple awards to his credit, and in recent time, he is extremely popular for his cost-effective suprachoroidal injection cannula that he has devised. He has 35 international and 25 national publications to his credit. Next slide, please. With us is Colonel Vipin Rana. He is one of the first MCH in vitreoretina surgery. He completed his fellowship from PGI Chandigarh. He is an associate professor at present at Command Hospital Eastern Command. He has 37 international and national publications to his credit, and one can see his vast academic prowess. And we have two young doctors who are filling in for a few of our speakers who could not make it today. Major Srishti Khuller, he is a senior resident ophthalmology. You may recognize her face from this year's Republic Day parade, where he led the first women contingent of Indian Army on the Kartavya Path. Next slide, please. And Dr. Mrinalini Singh, he's a Deputy Commandant of Sashastra Sena Bal. She'll be presenting on behalf of Dr. Ruchit Tiwari today. So without any further delays, we'll start with the presentation. The first presentation will be on the role of Brolucizumab in neovascular AMD and PCV. So why we wanted to bring out this IC was that the icicles were getting larger. And what are these icicles? When we looked at our data of the intravitreal injections that we had been injecting at Army Hospital RR, we found a very interesting trend. From 2018 and 19, where the predominant injection used to be ranibizumab, the trend was changing towards aflibercept and brolucizumab. Why this happened was an obvious reason, because this was the trend all across the country. But very interestingly, we found a rising trend towards brolucizumab because of its longer lasting action and cost effectiveness compared to aflibercept. These are at present the established usages of brolucizumab. I'll be speaking about AMD and polychoroidal vasculopathy, while my colleagues will be speaking about diabetic retinopathy and few of the novel applications. In these novel applications, we'll be covering a gamut of indications. So why we are calling it the Indian experience? Because when we talk about brolucizumab in India, the first study which came out establishing RCTs confirming the efficacy of this molecule was from our institute. Like the rest of the country, we also had initial setbacks with some severe IOIs. But as of date, we have completed 1,770 injections, and we have only had 4 serious IOIs, which have all been well managed, and none of our patients have lost vision compared to the baseline from where they started. Why this molecule behaved differently in India? This is probably the only reason that we have, because otherwise there is nothing different in the molecule which is manufactured here compared to elsewhere. So initially, I'll bring you to our study, which changed the mindset of our doctors in India toward this particular molecule. Where the West was reporting 4% serious IOIs, we encountered less than 1% serious IOIs. We took necessary approvals for the study, and our inclusion criteria were the same as Hawk and Harrier, and we were targeting the population with best-corrected visual acuity less than 6/9 and more than 3/60. I'd like to highlight this point here, that few of our colleagues have been trying to achieve success in burnt-out cases with less than 3/60 vision with multiple injections of Brolucizumab. We have to understand that beyond a certain level, these drugs will not work. Our exclusion criteria initially tried to rule out any evidence of intraocular inflammation in the cases that we were injecting. Again, I like to point out here that with our experience, we have realized that once the inflammation has completed its course and you are faced with an inflammatory CNVM, you can still go ahead and try this molecule with decent results. So it was a well-randomized trial. The protocol that we followed was 3 initial loading doses at 0, 4, and 8 weeks, followed by 4 weekly reviews. And at the 4 weekly review, whenever we found that any patient was meeting the retreatment criteria of 1 line drop in vision on logmark or a OCT increase of 75 micrometer of central macular thickness, or appearance of new IRF or SRF spaces, we were injecting. The same treatment criteria we recommend to be followed by everybody else when they are trying to re-inject Brolucizumab. One very important thing which we wanted to study was the ocular adverse events. Grade 1 and 2 events occur in any intravitreal injection. What we were interested in were the serious IOIs, where we required topical or oral steroids, and grade 4 were the serious IOIs where you needed oral steroids, which were the ones we focused mainly on. I'll be talking also about the 2 serious IOIs and how we managed it. Our patient characteristics at baseline between the 2 groups were quite well matched. We had about 56 patients in Brolucizumab arm and 58 patients in aflibercept arm. We had a slight male preponderance being a service institute, and the best corrected visual acuity and central macular thickness at baseline was well matched between the 2 groups. In addition to the central macular thickness, we were also looking at the fluid compartment on OCT in each of these cases. The best corrected visual acuity and the central macular thickness, as had been predicted by Hawk and Harrier, improved, though there was a small incremental benefit compared to aflibercept, but it was not statistically significant. So we started looking at how the central macular thickness was decreasing between the 2 groups, and when we looked at the fluid compartments, the intraretinal fluid compartment and the subretinal hyperreflective material, they behaved almost same between the 2 groups, but the subretinal fluid was the important part where we saw a tremendous decrease compared to aflibercept with Brolucizumab. So this established a better drying effect, and in a patient where you tend to achieve a wow factor, a patient with subretinal fluid is the ideal candidate. Another question which needed to be answered was that how many re-injections were required in these patients. So after finishing the first 3 loading doses, we tried to calculate that when were the patients being re-injected in the 2 groups. With this data, you can make out that most of the re-injections in Brolucizumab group occurred between the interval of 12 to 24 with a mean of 14.4 week interval, while in the aflibercept arm, most patients were still receiving re-injection at 4 to 12 weeks with a mean of around 6 weeks. Talking about the intraocular inflammation, we encountered one serious intraocular inflammation in this subgroup. So what we learned from our experience was that Brolucizumab worked as well as aflibercept. With our larger experience now, we believe a shade better, provided longer inter-injection interval, though it caused significant adverse events when we looked at the patient in a close follow-up manner. But they were all manageable. And I like to point out here that what most studies have brought out, including our study, were type 3 IOIs or grade 3 IOIs, where you see a lot of cell and flare. But most of these patients are asymptomatic. Patient never tells you that I have an issue. It is simply that you are calling back the patient every 4 weeks and subjecting them to a detailed examination. You are able to pick up these cell and flare. So we established the lower number of injection and lower number of serious adverse events occurring with Brolucizumab. I'll talk about the patient who suffered the serious IOI. Why so? Because it's important to know the other aspect of the drug as well, that what happens when this drug does not behave. So we had this 65-year-old lady, started with pre-injection best-corrected visual acuity of 0.62, and 72 hours after the injection had this picture. So the moment you see 72 hours prior to injection hypopyon, the first thought which comes to your mind is that this is an endophthalmitis. So we started prepping up our intravitreal antibiotics, but we paused for a minute and thought about the so talked about serious IOIs with Brolucizumab. We held back the intravitreal antibiotics, started the patient on oral and topical steroid, and this patient did well without requiring any intravitreal antibiotics. So this was not an endophthalmitis. This was one of those talked about severe vitritis episodes. For 8 months, the patient was not on any anti-VEGF, and after that, now patient has started reusing aflibercept. We never had the heart to start the patient on Brolucizumab again, and has a best-corrected visual acuity of 0.44. Now, compared to this, the second serious IOI, this we came across after our study had finished, was in a 72-year-old man who started with a pre-injection best-corrected visual acuity of 0.28, developed the vitritis 2 weeks after the 6th injection. So it is not defined that whether the person will develop an IOI after first, second, or third injection. It can be as late as 6th or 8th injection. And the time duration between the injection and the appearance of the IOI can vary from 3 days to 3 weeks. This again resolved by 5th day with treatment. And in this particular patient, we were able to restart the patient on Brolucizumab because this patient was extremely happy with the outcomes of the injection. So now what we have brought out new in this IC is we'll be showing you a 2-year follow-up of our new vascular AMD patient data, which were there in our trial, with a subset analysis of PCV. We are also planning a prospective study on PCV now. So we lost about 4 patients in the Brolucizumab group and 3 patients in the aflibercept group when we came to 104-week follow-up. The baseline demographic characteristics remained the same. When we talked about the best-corrected visual acuity and CMT at baseline, they were almost similar to where we started from. Those loss of 3 and 4 patients did not make a difference. But this is interesting. At 48 weeks, we see that Brolucizumab group had a 0.13 improvement on logMAR at 48 weeks, and the same effect was retained till 102 weeks, while the aflibercept arm had a 0.10 improvement at 48 weeks, and it became 0.09 at 104 weeks. This difference may look very trivial to you, but what is interesting is that the number of re-injections which were required to achieve this kind of result. So our patients in Brolucizumab arm at end of 102 weeks had 152 injections, while in aflibercept arm, they had required 328 injections. So this is what we have been talking about, that once you have more number of injections, the true intravitreal injection-related ocular adverse events will far outweigh the number of IOIs that you will see because of the molecule itself. When we talked about our PCV subgroup, we had 18 patients in the Brolucizumab arm and 23 in aflibercept arm. Please remember, this is the retrospective analysis of those OCTs. And the best corrected visual acuity was a shade better compared to the rest of the patient and was even better in the Brolucizumab arm at baseline when we started. But when we talk about the change in best corrected visual acuity, we realize that the stronger drying effect of Brolucizumab was seen in PCV cases also compared to aflibercept cases. And the story repeats itself that the number of re-injections after the first 3 doses continue to remain low. Just to bring out that how much do we trust the molecule today, this was a standard case of PCV, had developed a subretinal rebleed. You can see a scar with a fresh rebleed there. And this was about 12 days old. We went ahead and gave a subretinal cocktail of TPA, Brolucizumab, and an air bubble. And this patient achieved a post-surgical outcome of 6/36. So to conclude, the best corrected visual acuity gains are better than aflibercept. There is a greater drying effect. The number of re-injections continue to be lesser, and there is a better action in PCV subgroup, at least in our limited sample, and the adverse events, when they occur, are manageable, and they are far less compared to what had been reported earlier. I was speaking to Dr. Dudani from Mumbai in the morning. He said that he recently had a serious IOI, but he also believes that the way forward is to continue giving the injections. Thank you so much. There's our contact. Any questions at this point of time, or we'll take them after the first 3 presentations?
I'll just ask a question for benefit of others. Brolucizumab, one concern is always IOIs, but your big data shows that the concern is not that severe. But like in your case of that 70-year-old lady, what could be the pointers that it is not because of endophthalmitis, but it could be because of the drug itself? In that case, could you formulate some kind of pointers where it is related to the drug?
We have experienced 4 such serious IOIs till now. One very important thing is absence of pain. All 4 patients, 2 were in diabetic patients and 2 were in AMD patients. None of them complained of pain. Patients complained of diminution of vision and redness. So absence of pain, probably in our experience, was a significant pointer towards the event being related to intraocular inflammation, not attributable to infections. Yes, please, ma'am.
You for an excellent presentation and the great work that you guys are doing. And I wanted to know about, you're giving a cocktail. Now, in the cocktail, how much of each thing is there and how much are you injecting, the volume?
So what we are giving is 25 microgram of TPA, half dose, that is 0.03 ml of Brolucizumab compares to about 3.6 milligram total dosage, and 0.06 ml of sterile air. So the total volume which gets injected below the retina is 0.12 ml. So that you saw the bleb. And in addition, when you are injecting this, a little bit of this cocktail will definitely bubble out into the vitreous cavity through the same aperture from where you were injecting. So 0.12 ml is the bleb which is formed below the retina.
Calculate that much?
Oh, yes, ma'am. Thank you so much. With this, I'd like to invite my next speaker, Dr. Srishti Kular. She is speaking for Professor Sanjay Mishra. He could not be here today. His flight is a little delayed. Dr. Srishti.
Thank you, sir. So I'll be covering the experience that we had at our center with Brolucizumab in diabetic macular edema cases. Diabetic retinopathy and macular edema is a sight-threatening complication in the affected patients and is associated with microvascular damage and leakage of fluid, proteins, and lipids. Despite advances in treatment options, there continues to be a significant unmet need for effective and safe therapy in extended durability and at affordable cost. So I'll be covering under these subheads. So we conceived this idea of doing this study after FDA-approved dosage for ranibizumab in diabetic macular edema cases as 0.3 milligram, which is lesser as compared to its standard dosage of 0.5 milligram in CNVM cases. And even Kestrel trial reported similar outcomes in terms of efficacy in diabetic macular edema cases who were treated with 3.6 milligram and 6 milligram groups of brolucizumab. The logic behind this could be that intravitreal administration of biological molecules provides easy access to the pre-retinal space, which is a major target during diabetic retinopathy. So we enrolled 155 diabetic patients in our study, and after application of exclusion criteria, 102 patients were allocated to two groups. One group received brolucizumab 6 milligram, and the other received brolucizumab 3.6 milligram. Necessary approvals were sought from the Institutional Ethics Committee, and we registered our trial with the Clinical Trial Registry of India. And diabetic patients of either type were included in the study, but those who were optimized with oral hypoglycemic agents and with HbA1c levels below 10%, having non-proliferative diabetic retinopathy with center involving macular edema, leading to best-corrected visual acuity of less than 0.1 on logMAR chart, and central macular thickness of more than 300 microns were included in this study. Those patients who had PDR or any history of prior intravitreal treatment or laser treatment for diabetic retinopathy, or concomitant ocular disease of retina like uveitis, or history of any recent ocular surgery, or presence of any renal failure or any other cardiac event post anti-VEGF injection were excluded from the study. We followed pro rata regime for our patients for injecting. An interval of 4 weeks was kept between two injections, and at each visit, we noted the best-corrected visual acuity and central macular thickness. And all these patients were monitored for intraocular inflammation at day 1, 7, and 28 post-injection. Retreatment criteria was kept to be the presence of intraretinal subretinal fluid on SDOCT or reduction of BCVA of more than 1.1 logMAR on logMAR chart from the last injection, or central macular thickness more than 350 microns in the absence of SRF or IRF. We had kept a grading for ocular adverse events, like Sir has already discussed in the previous presentation. We graded them into 4 grades, the first one being only mild subconjunctival hemorrhage at the site of injection, to grade 4, which included hypopyon in AC and severe vitritis. These were our baseline characteristics for the patients enrolled in our study. So this box and whisker plot shows that the vision changes in the group receiving 6 milligram brolucizumab, and the change of mean vision from 0.74 on week 1 to 0.12 on week 28. We can also see that the number of outliers have reduced with time, and this study shows that study participants have had changes in their vision by the end of 28 weeks, which could be visualized by the outliers. Similarly, this plot also shows that the vision changes in the group receiving 3.6 milligram brolucizumab. The mean change has been highlighted, and even this chart shows that the study participants have had changes in their vision by the end of 28 weeks, which could be visualized by the outliers. So, significant improvement in best-corrected visual acuity was noted in brolucizumab 6 milligram group over the weeks, as depicted in this chart. And we had similar outcomes and improvement in the best-corrected visual acuity with 3.6 milligram group, as you can see here. Similarly for the CMT also, which was noted to be same in both the groups, with the who received brolucizumab 6 milligram as compared to the ones who received 3.6 milligram. And even the number of injections remained to be similar in both the groups. The ocular adverse events that we noted in each group were also comparable. There were 5 patients who had significant ocular adverse events in our group A, that is 6 milligram group, which were managed with PST for 40 milligram, and they gradually improved in their BCVA, and we could not find any other reaction post second injection. Similarly, in the other group, there were 4 patients who had adverse events, which were managed similarly. So these two were our 2 interesting observations which were noted. We noted that HbA1c dropped significantly in our patients, but this can be a confounding factor as patients who realized to be having diabetic retinopathy would have started strict dietary control. And secondly, presence of SRF has been rarely reported in literature in diabetic retinopathy cases, but it was found significantly in many of our patients of diabetic retinopathy. So to conclude, we found that Brolucizumab is effective in central involving diabetic macular edema, and it can be used in lower dosages also, that is 3.6 milligram. Pro-Renata regime can be followed for such patients, and patients required 3 injections in 28 weeks on an average, thus reducing the cost burden and this recurring visits to hospital. And adverse events are manageable, and no contraindication are proposed by us to reuse Brolucizumab. Thank you.
Thank you so much, Srishti. On behalf of Professor Sanjay Mishra, I'd like to inform that why this particular comparison was planned between 2 dosages of the same molecule. The idea behind this was that one vial can be fractionated comfortably into 2 injections, which gives you about 0.03 to 0.04 ml in each of the injection. Though the company people sitting here may not agree with me, but it is the practical way forward. And it gives close to about 14 to 15,000 costing per patient, with an inter-injection interval of about 12 to 16 weeks in the long term. It is a very effective and safe molecule to be used in diabetic macular edema patients. Regarding the 2 IOIs which occurred with our patient, people always ask us that you cannot give them oral steroids. What will you do? So we show the way forward that if you give them peribulbar steroids, they work equally well. You can give them PST. Few of my glaucoma teachers may not agree, but these patients, when they are given PSTs, they tend to have resolution of inflammation, and it is not a given that these inflammation will recur. So the next time onward, you can go ahead and keep trying the molecule again. Any questions?
I have. Not related to what you are saying, Pradeep, but I have one question, and that is, you will have tried it in mainly DME.
Yes, ma'am.
Now, as you know that we use a lot of your molecules also in glaucoma, especially glaucoma surgery in NBG. So what my question was that how much of its effect have you seen in NVI, NVA, etc.?
Ma'am, that is one very good thing that we will be talking about. This is one of the novel usages of Brolucizumab, especially in cases of neovascular glaucoma, where when the intravitreal injection used to be given, people were advocating that you must give a small dose in the AC also, some people suggested, because the efficacy of ranibizumab was not so much. Now here we have a molecule which is smaller, penetrates much more, and has got 36 times higher molar concentration available of the same anti-VEGF action. So when we started injecting Brolucizumab in our patients of NVI, the NVIs disappeared beautifully. We did not have to worry about a rebleed during the next surgery, whether it was a glaucoma surgery or a combined cataract surgery, and the surgical field remained absolutely clear. So that is our experience with NVI with Brolucizumab. So without further ado, I will now like to invite Dr. Mrinalini, who is speaking on behalf of Dr. Ruchit Tiwari. She'll be speaking about novel applications of Brolucizumab.
Good morning to all. I'm Dr. Mrinalini Singh, resident in ophthalmology at Army Hospital RNR. I'll be filling up for Dr. Ruchir Tiwari with his presentation on novel applications of Brolucizumab. Our clinical cases will be discussed as: first case is for RP-RIP. Our patient was an 83-year-old gentleman with a best corrected visual acuity of 6.9 in left eye. He presented first in September 2020. Right eye had old retinal detachment and was PL negative. On fundus evaluation, there was drusenoid PED in left eye, and patient was managed conservatively under close follow-up. These are the serial OCTs in September 2020 when patient was maintaining a best corrected visual acuity of 6.9. In April 2021, there was sudden loss of vision and visual acuity fell to counting fingers close to face. On fundus examination, there was a large macular detachment with underlying yellowish lesion. Patient was planned for loading doses of injection ranibizumab followed by treat and extend regime. At 6-weekly interval, ranibizumab was given with partial response. No vision gain was obtained, and patient was planned to switch to Brolucizumab. Brolucizumab, after 4 weeks, there was significant resolution and BCVA improved to 660. After 8 weeks, a second Brolucizumab, all the SRF was gone, minimal intraretinal fluid was there with the BCVA improving to 624. After 6 weeks, OCT was stable and patient maintained a BCVA of 624. At 13 weeks interval, a third Brolucizumab was planned, and due to disease recurrence, and BCVA had dropped to 660. After 12 weeks, the OCT was stable, BCVA was 624, and patient was again planned for a Brolucizumab 4th dose. This is the OCT in February 2022, where there was early disease recurrence and BCVA was 624. Brolucizumab 5th dose was given, and patient was stable with a 6th dose received after 12 weeks. Our second patient was of myopic CNV. 69-year-old male, both eyes pseudophakia with pathological myopia. There was sudden blurring and metamorphopsia in right eye for 1 month. Left eye had poor vision due to myopic CRA. The best corrected visual acuity in right eye was 2/60 and left eye was counting fingers. Examination revealed myopic CNV in right eye and disciform scar in left eye. This is the OCT in August 2021, where patient was injected Brolucizumab and he maintained a vision of 636 till October 2022. A third patient of pachychoroid CNV. 40-year-old female, working mother with pachychoroid disease with type 1 CNV. From October 2019 to September 2020, she had received 14 ranibizumab and 2 aflibercept injections and had maintained a BCVA of 6.9. These are her OCT pictures, fundus photograph. In later September 2021, with BCVA of 6.9, patient was switched to Brolucizumab. And early November 2021, BCVA was 6.6. These are again the serial photographs from December 2021 to September 2022, where patient was injected Brolucizumab and attained 6.6 vision in November 2022. A second case of a 52-year-old lady presented with blurring of vision in the right eye in August 2017. Her best corrected visual acuity was 618 in right eye and 6/6 in left eye. Fundus revealed dull FR in right eye. Both eyes had few pigmentary changes and few drusen's. OCT of right eye showed subretinal fluid with thickened choroid. OCT left eye had some RP alterations, single drusen with pachychoroid. FFA and ICG showed no leakage. OCTA had no membranes detected. Patient was diagnosed as a pachychoroid pigment epitheliopathy with SRF or maybe a pachychoroid neovascularization, and left eye had pachydrusen. No anti-VEGF was advised, and patient was followed up for 3 months with no drop in vision. These are the OCT pictures from August. The next follow-up was in April 2019. Patient received 3 ranibizumab in December 2018, January 2019, and Feb 2019, and 1 aflibercept in March 2019 elsewhere for NAMD. There was partial response and BCVA 618 despite waxing and waning of the fluid. These are the pictures from Feb 2019 and March, where fluid is increasing and decreasing. BCVA is maintained at 618. In April 2019, BCVA of 618 in right eye, 69 in left eye. These are the OCT findings. Patient was managed conservatively. There was history of prior failure to ranibizumab and aflibercept, and also there was no drop in vision, so patient was not convinced for repeated aflibercept. The patient came back again after 14 months with the same best corrected visual acuity. In June 2020, maintaining the same status. Both eyes had early cataractous changes and was managed conservatively. In Feb 2021, patient was convinced to go for a cataract surgery, BCVA of 660 in right eye from 618 and left eye maintaining 69. Right eye had nuclear sclerosis grade 2 and left eye grade 1. February 2021, BCVA 660. This is the OCT picture. Patient was injected Brolucizumab. Followed up after 1 month, and BCVA had improved to 624. In March 2021, 660. In April 2021, 624 after Brolucizumab. The change was noticed in a 4 weeks period. Patient had lost to follow-up for another 8 months. Right eye NS2, left eye NS1, BCVA right eye 624 and left eye 612. In November 2021, with the best corrected visual acuity of 624 in right eye, and these are the serial OCT pictures from 2017 to 2019 and November 2021. A third case of recalcitrant idiopathic CNV. 50-year-old female, decreased vision in the left eye, diagnosed as CNV elsewhere, received 3 monthly ranibizumab and 1 aflibercept, best corrected visual acuity of 618. Even with treatment, there was no further improvement. Last injection was given 3 months prior. It was delayed due to COVID. This is the fundus photograph OCT picture from 2021, June 2021. Patient was injected ranibizumab. After 2 weeks, BCVA is 618 with mild SRF resolution, and after 4 weeks, BCVA of 618 with recurrence of some fluid. Patient was planned for first dose of Brolucizumab, and in 4 weeks, BCVA attained was 69, no disease activity. After 8 weeks, BCVA 612 with recurrence of some fluid is there. Patient was again planned for Brolucizumab. And 2 weeks later, BCVA 69 with no disease activity. Patient maintained a BCVA of 69 with mild SRF after 6 weeks, also with early disease recurrence was there. And patient was again planned for a third dose. Mild nasal SRF, and patient defers injection for again 2 weeks because he maintained a BCVA of 69. And frank recurrence occurred after 8 weeks when patient had the BCVA 612, increase in SRF and SRH. Brolucizumab fourth dose was planned after 8 weeks. In total, patient received 8 injections so far. Injection frequency was 6 weeks and visual acuity maintained at 6.9. Another novel application was on inflammatory CNV. A 43-year-old female with a history of bilateral peripapillary choroiditis diagnosed in June 2018. Patient was treated with tapering doses of oral steroids, developed bilateral peripapillary CNV after 1 month. Over next 2 years, both eyes received 12 ranibizumab and 2 aflibercept each. This is the fundus photograph and OCT picture in April 2020. December 2021, right eye had a vision of 660 and left eye 624. Patient was injected. In October 2020, right eye had 69 and left eye had 66. Another application where we have used Brolucizumab is CRVO with advanced glaucoma. It was a 74-year-old male presented in June 2021 with NS1 IMSC. IOP was 13 on 3 medications. Optic nerve had bilateral advanced optic nerve head cupping. Right eye showed non-ischemic CRVO with macular edema, and left eye had ERM with pseudo-hole. History of 3 monthly ranibizumab. A previous year, there was some gain in vision. No anti-VEGF treatment since last 6 months. Advised right eye ranibizumab monthly till there was a CMT of 300 or BCVA stabilized, followed by pro-rata regime. Lost to follow-up for 3 months. Patient presented again in September 2021 with right eye BCVA of hand movements close to face and pressure of 54 mm Hg. History of Ozurdex elsewhere in right eye. 2 months back, patient had stopped all other anti-glaucoma treatment. Glaucoma was medically managed. 1 week later, patient came with normal IOP on 5 medications and a BCVA of 3/60. In September 2021, the CMT was 567, received 3 monthly ranibizumab injections, and in January 2021, CMT reduced to 453. Patient was switched to Brolucizumab. March 2022, CMT further reduced and patient lost to follow-up for 2 months. And after 16 weeks in May 2022, CMT had again reached 870. Patient was planned a second Brolucizumab. After 20 weeks in October 2022, CMT of 286 with the best corrected visual acuity of 618, and patient is still on follow-up.
Please carry on, Mrinalini. We have sufficient time. Please carry on. Please finish the presentation. Can we have the presentation back, please?
Sir, last. Done.
Thank you so much. So this particular presentation was meant to make people aware that Brolucizumab can be extended to few novel indications. 3 important things which I want everyone to take home today is, 1, that in inflammatory CNVMs, once the inflammation subsides, the drug can be used. It has not only been used at our center and with Dr. Tiwari, but by many other people in post-inflammatory CNVMs with very decent results. Another take-home is the effect this particular drug can achieve with a lower dosage. In our subset of diabetic retinopathy patients, we have already proven this. Why we believe that the lower drug dosage works is because the disease is predominantly pre-retinal in cases of diabetic retinopathy and CRVO compared to neovascular AMD where the disease is subretinal. Now, when you are using half the dosage, it works very well for patients of glaucoma. Usually, in patients of glaucoma, once you end up injecting a 0.05 ml dosage also, right after the injection, if you have not done an AC tap and there's been no leak from the injection side, if you measure the IOP, the range is about 30-31. So you have given a good IOP spike to the patient. But if you are using Brolucizumab with a 0.03 ml dosage, the IOP spike is not so great. So we recommend using it for patients of glaucoma who require anti-VEGF injection at a lower dosage. The house is open for discussion. Any questions, please? In that case, I'd like to invite our esteemed colleague, Professor Avdesh Oli, who will be speaking a little different from what all has been spoken till now. He'll be talking about current and translational research in anti-VEGFs and what the future holds for us.
Good morning to all my teachers and dear colleagues. So I'll be taking you backward in the history and forward in time about the anti-VEGFs, their newer molecules, and newer methods of injection. So the journey started when we called this anti-VEGF as factor X, and then slowly newer molecules, they appeared in the horizon, and now we have ample choices of molecules who have longer duration of action and better ocular penetration. So this is just a graph showing how in 1853 the disease most commonly for which it is used, that was diagnosed, and then newer molecules, they started appearing. So this is the basic pathophysiology in dry AMD and wet AMD. More so in wet AMD, 3 sites the drug should act is new vessel formation and fluid exudation and changes in the drusen's over time. So these are the 3 targets for inflammatory factors: new vessels and fluid accumulation. Any drug has to be, if it has to be efficacious, then it has to affect these 3 sites. So for the future, there are ample number of molecules which are under various phases of trials, and I'll cover them in detail slightly later. But the most commonly used anti-VEGF agents are as shown in the slide. The molecule just before Brolucizumab was aflibercept, which is still in wide use. There are new drugs which are being tried, wherein they act on the oxidative stress and other external factors. However, with all these molecules, still there is biggest unmet need of treatment burden to a country like ours. The frequency of injection. We may reduce the frequency of injection by any of the molecules, but if we talk about the total financial loss to the person, suppose he has to travel, a person, generally these patients are elderly, and suppose a bread earner is accompanying that patient, then the frequency becomes important. Then the response, sometimes the patient after a certain number of injections becomes non-responder. What to do in those situations? And a patient compliance. When I was a resident, I always used to think that the cost of one injection is 50,000 rupees. That would equivalent to one iPad. And how a common man could afford that every month or every 3 months? And also the duration of action. So to answer some of these questions, biosimilars, they were manufactured mainly because the patent of these drugs was expiring, and newer molecules, they were ready to be launched. A biosimilar is defined as a product which is comparable in quality and clinical evaluation. The cost is reduced because it is made by reverse engineering. However, this immunogenicity, which actually erupts time and again with these products, is important. Now even there is a concept of bio-betters, because since we are doing reverse engineering, it is possible to make these molecules. So this is just a graph showing the comparative cost of the drug if taken into account the duration of action. So is the big change around the corner with these biosimilars? Yes, but there are patent issues, and cost is also one concern. So definitely the lessons which we have learned from all these anti-VEGF era is that there is a separate, different need for the developing world. We need to have compounding pharmacies, and also pharmacovigilance and quality control, which is very important for reducing the number of intraocular inflammations when we use these drugs. Another drug not very popular because not all the institutes can actually import it, but it is a isomer of aflibercept, and it has also given excellent results. During my fellowship in LVPI, large number of injections, when they retrospectively were studied, it was found that the comparison was similar to the aflibercept. Brolucizumab is definitely a superior molecule because it's a single chain fragment, which is the smallest functional unit of antibody, and however the chances of inflammation are more, which needs to be identified at earliest and managed appropriately. So it is because of the engineering of Brolucizumab for efficacy and durability, and it has got superior anti-VEGF binding ability per volume. Newer molecule like conbercept, it's an anti-VEGF fusion protein, And it has been in use in China since 2013, and various well-structured trials have also shown superior results. Another drug is Faricimab, which actually is a molecule which acts as at two antibody sites. One is the anti-VEGF Ang receptor, and other is at VEGF-A Fab. So this working at two sites makes it more scientifically plausible to have superior effect at VEGF-A and Ang2 site. Various trials of phase 2 like Avenue and Stairway, and phase 3 like Tenia and Lucerine, they have shown that they could be treated, 60% of these patients could be treated quarterly, and in 80% the treatment interval was for 3 months or more. However, we use this anti-VEGF as Ganga Jal to wash off any sins of the retina, but always there is a dark side to the moon, and we should always think of systemic side effects which these drugs can cause. And as such, these patients are elderly and have, most of them would have some or other comorbidity. And always during injections, standard guidelines should be followed, like use of perioperative antibiotic and use of facial mask. While for a comprehensive ophthalmologist, whenever giving such injections, we should talk minimum in the OT, and always we should use facial mask, because most of the time the offending organism is from our own oral flora. There are certain other delivery systems which are actually being used in patients. They have a reservoir of the drug, and there is continuous diffusion of the molecule in the ocular cavity. And this is a port delivery system. The surgery is not very difficult. After making a sclerotomy, you place this reservoir in the eye, and then it can be topped up as and when required. So this is the extrascleral flange and a septum with a silicone coating and body. This is how it looks inside the eye. So there is a clinical trial, ladder clinical trial, wherein the top-up period could vary. The time to refill was 15 months. So definitely it will cut down on the visits to the patients. There are various other drugs like sunitinib maleate, and these are other drugs which are on the horizon, which are in the development phase. Another thing is about the anti-VEGF injections. Now they are available in pre-filled injections, so it is safer, because any manipulation, any drawing out from the vials, that is avoided. And also, we have now sharper and thinner needles from 34 gauge to 32 gauge. So there is a study which shows that finer needles, they may cause sudden IOP rise. So we have to be careful about that. Then now even newer indications, even non-proliferative diabetic retinopathy and retinopathy of prematurity, they are also in the expanded indications for anti-VEGFs. There is another promising strategy for sustained anti-VEGF delivery in the retina, that is with the nanoparticles. And it has got, like Ozurdex, it has a core where the drug is in the reservoir, and slowly it is released. And these are various phases of drug release from these hydrogel-based sustained delivery systems. Even now, there are composite drug delivery systems in various phases of development, and they have easy migrations, but they can cause easy migration of particle, and they are high toxicity. Gene therapy is no longer science fiction now, and various drugs, they are under trial. And it basically also gene editing with a CRISPR-9 gene, which has got high efficacy and high cost performance. However, there are some concerns with gene therapy, like long-term efficacy, and it is still very expensive. Another space which has been explored extensively nowadays is the suprachoroidal space, where you deposit the drug. However, the anti-VEGF injections into this space has not given very favorable outcome because of rapid diffusion of the drug from this space. But with newer molecules and newer delivery systems, this space is going to get its due attention. The devices to inject in suprachoroidal space, they are not available commercially. They are just a part of various trials. However, this is one drug which can be given through 3 routes, subretinal, and suprachoroidal space. So this will be an in-office procedure because it will be suprachoroidal, so the intraocular infections and those chances would be less. Another suprachoroidal treatment is a retinal restoration technique wherein some cells are injected and the aim is to produce the growth factors at chorioretinal level. So to facilitate this, we also innovated a suprachoroidal injection needle, which is a simple modification to a 26-gauge needle, wherein we use the outer sheath of a cannula to cover the needle, and only the beveled edge remains exposed. And like a subconjunctival injection, you just make a perpendicular entry, and then the drug can be delivered. We generally give 4 milligrams of triamcinolone, which we have tried till now. And there not had been any complications. So this route, as I said, will be more useful even for delivery of gene therapy. And now this is getting word over, it has become popular, and it is getting citations and various other uses people are trying. To conclude, newer molecules, biosimilars, and delivery systems are in pipeline. They will be less invasive, longer acting, and sustained release formulation. Great promise and potential that delivery systems will significantly impact the standard of care. Thank you.
Thank you, Dr. Oli, and fantastic presentation. But everyone here will like to know your thoughts about the new molecule, especially faricimab. Everybody is talking about it. Now here we have a molecule which, as far as the theory is concerned, seems to be excellent, that it will be acting on 2 targets rather than 1. But it's surprisingly priced extremely high, close to about 60 to 70,000. So what are your thoughts about this particular?
Yeah, when we talk biologically and scientifically, definitely it's a promising molecule because it will be acting at 2 receptors. But the real world data still it is awaited to actually say that how much would be efficacy and what would be the treatment interval. And cost-wise also, depending on the treatment required, the treatment interval which will be required, it will be time only which would tell, though the trials support that it is the most efficacious molecule right now.
Thank you so much. Any questions from the audience? Then I'd like to invite my very dear friend and young dynamic leader in retina, Dr. Vipin Rana, to speak about economic challenges of anti-VEGFs in Indian scenario. And he'll be filling up for Colonel Raji today.
Good morning, everyone. As Sir said in his previous talk, that he used to think 1 injection is equal to 50,000, and which is equivalent to 1 iPad. So how a common man can afford this? So I'll be talking absolutely on this thing. Michelson introduced diffusible glycoprotein factor X in 1980, which showed angiogenic properties resulting in proliferation and increased permeability of the vascular endothelium. And decades later, this 40 kilodalton molecule was recognized as VEGF, which we all know is released in response to the hypoxia. And it is being released by the retinal endothelial cells, Muller cells, and the retinal pigment epithelium. And it leads to abnormal angiogenesis, which is seen in proliferative diabetic retinopathy, CNVM, CRVO, and ROP. And we all know that all these diseases, they require anti-VEGF for its control. So let's talk about the prevalence of various retinal disorders. So if we talk about the ocular diseases, so in population above 65 years, on estimation, by year 2025, approximately 1/3 of all these diseases will be the retinal diseases. And as such, there is increase in the number of ARMD patients, and which leads to burden in the current eye care infrastructure, and it leads to lowering the ability to perform the activities of daily living. It also hampers the direct costs like inpatient and the outpatient expenses and the work absence, and leads to loss of the productivity. So let's talk about the Indian scenario. In Indian scenario, if we talk about the early ARMD, we have approximately 16.37% of the patients, and in late ARMD 2.32% in India, which leads to chronic clinical, economic, and social burden. So approximately 18 to 22% of the Indian population is below the poverty line, and India's per capita income is mere $720 as compared to the $47,740 of the United States. So the estimated 0.1 million patients of wet ARMD in India will be spending approximately 1.2 billion as drug costs only. And from where this cost will be covered? We all know that this cost will be covered either by the insurance companies or will be sponsored by the government agencies. So these injections are administered once a month, or a pro-rata protocol is used, where the frequency depends on the OCT findings, and the studies have shown the usefulness of treatment extent also. So the more frequent injection scenarios incurred the additional costs, and that leads to the increased burden on the government. So the additional patient benefits were substantially higher than those of the less frequent injection scenario, which results in higher societal value. So as per the studies, the management of ARMD patient costs 8 times more money. Now, the patients receiving intravitreal anti-VEGF are expected to be compliant and should follow up regularly to receive their next scheduled dose. But 51.54% patients were lost to follow-up as per one study. And what were the reasons to loss to follow-up? The reasons were non-affordability, treatment elsewhere, shift of residence, no improvement in vision, transport issues, health issues, and expired or not willing. So the limitations for the treatment are invasive treatment. So some patients, they might be scared of getting these injections. Multiple treatments for 2 to 3 years, that leads to the poor compliance, and obviously expensive and unaffordable in developing nations. Insurance regulatory and developmental authorities of India included intravitreal injections under insurance coverage. Also there are challenges in the implementation which do exist, and the annual cap for the injections, that is also there. The total number of injections. And if we talk about the cost-effective analysis in the Brolucizumab versus aflibercept, the data which I'll be showing this has been taken from the Hawk and Harrier studies. So it is on the basis of the administration, on the basis of adverse events, and the disease monitoring. Now, the Brolucizumab reduces the economic burden of the intravitreal injections. It is preferred by those who want less injections, and obviously the less injections reduces outpatient workload, and it also leads to the less waiting list. So in a nutshell, improved vision associated with anti-VEGF treatment may provide economic value to the patients and society. Choice of anti-VEGF depends upon patient affordability more than science. Almost every patient will require repeated injections. So look for affordable alternative compounds. Discuss with patient before starting the therapy. And potent longer-acting drugs are now available to us that promise even better outcomes with fewer injections. So to conclude, anti-VEGF treatment has generated billions in benefits to patients. Unmet need still remains, and the novel therapies with better efficacy, more durability benefits, or mechanisms that reduce discontinuation may lead to substantial benefits. The drug industry should review the entire pricing policy of these drugs in developing countries like India. Thank you.
Thank you so much, Dr. Vipin. Any questions for him? So this has been one of the very important aspects of treating patients who require anti-VEGF, that is the pharmacoeconomics. We have been speaking about these pharmacoeconomics at every forum, and I am thankful to Dr. Lalit Verma for taking up this matter, both from the society, and we have been doing our bit at the national level by approaching the ministry for allowing certain allowances when we are injecting these drugs. There are two ways we are addressing the issue. One is the way in cataract surgery, we get a reimbursement for cataract surgery through the National Program Control of Blindness if you are registered with them to a tune of about 700-800 rupees. So a similar allowance can be made for giving an intravitreal injection. The second thing we are targeting are tax holidays for the companies, Indian companies who are manufacturing these anti-VEGFs. And we are trying to talk with the major multinational players to set up their manufacturing at our country so that we can have a certain cost reduction. That being said, why we speak so much about Brolucizumab is that the cost of the molecule has not been priced at a prohibitive rate. The durability of the drug has been proven, and in our experience, the halving of the dose has worked well. So effectively, there has not been a cost escalation, but a cost decrease when you compare this originator molecule to the biosimilars of ranibizumab which are available today. If there are any questions from the audience, we'd like to address them. If not, then I'll thank the AV team for excellent support and AIOS for giving. Oh yes, we have a question. Yes, there are. The systemic contraindications remain the same as with other anti-VEGFs. If a patient has had stroke, then for next 3 months, they should not be injected. In a case of recent MI, again, for next 3 months, they should not be injected. In patients of ROP, we have still not tried this drug because the systemic absorption of this drug is believed to be much higher. We tried obtaining a CTRI for a trial of ROP, but we were denied on the same principle that our neonatologists believe that this amount of drug, when it will enter the bloodstream, how it will affect the growth of the child is not certain. In the same vein, it is not advocated for pregnant women, especially in their first and third trimester. Now, it's very interesting that we speak about the nephrological indications for avoiding this drug. So, very recently, if you see, especially from the Mumbai zone, there have been reports by our nephrologists that in few of the patients, when they were given anti-VEGFs, their CKD control worsened. But to mind you that these are reports from one particular zone as of today. So we do not have a clear-cut nephrological contraindication to the use of the drug. Yes, in future it might arise. You are very right that at present we are having report from the Mumbai zone and around about the contraindications in patients of CKD for using anti-VEGFs. So once again, I'd like to thank and close this session. Thank you, AIOS, for this opportunity. I'll request all the presenters for a group photograph.